Okay. Can someone describe this?
This is a section of liver.
Okay.
And it has the section shows dilated central veins.
Very good.
The hepatocytes near the central veins show necrosis.
Okay, very good. Okay, near the central veins, if you see here there is necrosis, and some viable areas are also seen. Okay, and some hemorrhage is also seen. Okay, so here we can say that this is the section from the liver where dilated central veins are seen, and hemorrhagic necrosis of the hepatocytes around the central vein is seen, and in between there are viable hepatocytes also. Okay, there is hemorrhagic necrosis. This is a chronic venous congestion of the liver. So why do you say this is a section of a liver?
So cords of hepatocytes are seen.
Very good. This is a central vein, and from the central vein towards the portal triad there are cords of hepatocytes, which will be arranged in either a single or maximum 2 layers of hepatocytes. Okay, so these are all, there are lobules of hepatocytes, right? So this is a liver where there is hemorrhagic necrosis surrounding the central vein and area of viable areas in the other areas. So this is a chronic venous congestion of the liver. So if it was a chronic venous congestion of the spleen, what would you see?
So you would see red pulp, white pulp.
Dilated sinusoid. Okay, dilated sinusoid. So then there is a something body, which is a peculiar body, which we see in spleen CBC.
Gamma antibody.
Okay, gamma antibodies. Okay. So when this comes in your exam, do not write CVC. Okay. Write chronic venous congestion of the liver. Do not write CVC of liver. Your points will be deducted. Right? We all know that CVC is chronic venous congestion. Okay, but you have to write the full form, chronic venous congestion. So we have already discussed this. Okay, anyone describe this, please? 11th slide. What is this? The diagnosis is there. You can just describe what you can see.
The section shows an abscess.
Very good. First, there is an abscess. Abscess means there is seeds of neutrophils. These all cells, okay, these are neutrophils. See, you can see the segments of the neutrophils. It is not seen like what you see in the hematology slides, like peripheral blood smear, what we see. It is not seen like that because this is a biopsy section. Okay, so you can see these are neutrophils. This is seeds of neutrophils. So this is an abscess. Okay, and rest.
Basophilic filamentous colony in the center.
Very good. Basophilic filamentous colony of organism or bacteria in the center. Okay, and what rest? What else?
Splendor-Hopley reaction around the colony.
Very good, very good. Splendor-Hopley phenomenon or reaction is seen around, which is this. Can you see this? If you see nicely, you can see that just surrounding the basophilic filamentous organism, you can see there is a intense eosinophilic reaction. Okay, this is the Splendor-Hopley phenomenon. Can anyone tell what is Splendor-Hopley phenomenon? Why it occurs?
It is the in vivo formation of intense eosinophilic material.
Very good.
That has star-like appearance around the bacterial or foreign body colonies.
Very good, very good.
And
And why it is formed?
Antigen antibody reaction.
Very good, very good. That is the antigen antibody complexes, right? Okay. So here the section shows an abscess with basophilic filamentous colonies of the bacteria are seen in the center of the abscess, and there is presence of Splendor-Whipple phenomenon, which is the microorganism surrounded by radiating intensely eosinophilic material. Okay, the 12th slide. Describe this.
So it is a section rhinosporidiosis.
Okay, rhinosporidiosis.
And the tissue is lined by pseudostratified ciliated columnar epithelium.
Okay.
And
Okay.
sporangia are seen, and neutrophilic infiltration.
Okay, sporangia are seen. Okay, these are the sporangia. Okay, these three which you are seeing, these are the sporangia. Okay, here if you see here, okay, I just forgot to discuss the questions. Okay, here in the chronic venous congestion, here the history will be patient had come with a history of right-sided heart failure. Okay, right-sided heart failure means whenever there is right-sided heart failure, then the back pressure will ultimately there will be back pressure to the liver bed. Okay, that you have to know. Therefore, there is chronic venous congestion of the liver. So, identify the lesion, chronic venous congestion of the liver. Describe the microscopic feature. We have already talked about it. What is heart failure cell? What is heart failure cell?
So, hemosiderin-laden macrophages found in alveoli of patients with left heart failure.
Okay, very good. Very good. It is seen in CBC of the lung. Yes?
Yes, sir.
Okay. Those are the which macrophages? Hemosiderin-laden macrophages because of the rupture of the RBCs, and the hemosiderin will be taken up by the macrophages. Okay, because of the congestion, the small capillaries in the lung will be ruptured, and there will be liberation of the RBCs, which ultimately will liberate. What will RBC liberate?
Hemoglobin.
Hemoglobin. And which pigment will hemoglobin have? Hemosiderin. Okay. They will be taken up by the macrophages. So hemosiderin-laden macrophages will be there. Those are known as heart failure cells. So in this actinomycosis, a 20-year female patient presented with an abscess. Okay, the most common presentation of actinomycosis is abscess. On examination, some yellow granular material is seen coming out from the sinus. Okay, what is the diagnosis? Mention 2 points to support a diagnosis. So this we have already discussed. Now, here I think Shreya was talking about this, right?
Yes, sir.
Okay. You were telling that there is a pseudostratified ciliated columnar epithelium with the stroma, which is edematous, and there are presence of
Sporangia.
sporangia of rhinosporidium. Okay, and there are many inflammatory cells comprising of acute and both acute and chronic inflammatory cells. These are all the inflammatory cells. These are the blood vessels. If you can see, these are all the blood vessels, small blood vessels, whereas these small tiny black things, these are the inflammatory cells. If you can't recognize them, these small things are inflammatory cells. This is a plasma cell, this is a lymphocyte, again plasma cell, and there are some neutrophils also. Okay, here there are some neutrophils also, and there is areas of hemorrhage. And not only stratified squamous, pseudostratified columnar, there is the metaplastic squamous epithelium also on this side. Whatever there is presence of sporangia of different size. Okay, so sections show a tissue lined by pseudostratified ciliated columnar epithelium. The subepithelium shows sporangia of different sizes, and tissue shows infiltration by the chronic inflammatory cells, example lymphocytes and plasma cells. So you should tell this. Otherwise, the patient presented with a polypoidal nasal mass causing nasal obstruction. This will be the history. What is this slide showing? Okay, you have to write that. And means what is the diagnosis? The question is asking, because the supporting points are already asked in the second question. Mention 2 points to support your diagnosis. Okay. Any confusion in these slides?
No, sir.
Okay, then we'll move ahead. Please describe this. Describe this slide.
Sir, it is the section from the lung tissue.
Okay.
There are alveolar spaces which are
Very-
filled with
very good.
neutrophils.
Okay, filled with neutrophils.
And there is alveolar septa which shows carbon pigments.
Okay, with carbon pigments. Very good. It is a pneumonia. This is a slide of pneumonia. Okay, what do you mean by pneumonia?
Infection of lung.
Okay, infection of the lung, inflammation of the lung parenchyma. Okay, inflammation of the lung parenchyma mostly due to infection, but it can be chemical pneumonia also. It can be okay there. If you see in this picture, this is a slide. Okay, this is a microscopic picture. If you see, these are all alveolar spaces. Okay, these are all alveolar spaces. What is the lining of the alveolar spaces?
Simple squamous cells.
It will be by the pneumocytes.
Yes.
Okay.
Pneumocyte type 1 and type 2.
Yes, type 1 and type 2. And there will be presence of Clara cells also. Yes. And actually, these alveolar spaces should be empty and they should be filled with air, so that there is a exchange of oxygen with carbon dioxide. Yes,
Yes, sir.
that is how a lung works. But here, if you see, there is, because of some infection, there is inflammation, and all the exudates means all the inflammatory cells, there are macrophages, there are dead cells which are occupying the alveolar spaces. So the problem here is that the space which should be occupied by the air is now occupied by the exudates. So there won't be normal air exchange, oxygen and carbon dioxide exchange. Yes, is that the problem?
Yes, sir.
Okay, so here you just have to say there are multiple alveolar spaces, which, and this is section from the lung with multiple alveolar spaces containing seeds of neutrophils, degenerated cells, and there will be pigment-laden macrophages or carbon-laden macrophages. Okay, here whatever you told is very correct, and a question might be, a 7-year-old patient comes with a high fever and rusty sputum. Okay, biopsy from the lung was taken. Identify the lesion, mention 2 points to support your diagnosis, and what is the stage of the lesion. So let's discuss about the types of pneumonia. What are the types of pneumonia?
So lobar pneumonia and bronchopneumonia.
Okay, lobar pneumonia and
Bronchopneumonia.
bronchopneumonia. These are the types according to the anatomical location. Okay, according to the etiology, so what is asked in the exam, the types of pneumonia, whether it is asked due to according to the etiology. Okay, if it is asked, then you have to write it will be bacterial pneumonia, viral pneumonia, and chemical pneumonia or fungal pneumonia, or okay, you have to write this way. Otherwise, you have to write hospital acquired pneumonia or community acquired pneumonia or atypical pneumonia. This is the other classification, but here we are talking about the anatomical location, which is the lobar pneumonia and the bronchopneumonia. So what are the stages of lobar pneumonia?
Congestion,
Congestion,
red hepatization, gray hepatization, and resolution.
Okay, these are the 4 stages of lobar pneumonia. Okay, in the lobar pneumonia, pneumonia goes through 4 stages. The first one is congestion. Congestion, why there is congestion, or what happens in congestion?
Capillaries are congested.
Is filled with
Are congested.
Okay, very good. Then red hepatization. Then what happens in red hepatization?
RBCs are seen in the alveolar space.
Okay, whenever there are RBCs, then there will be a red color. Okay, reddish color. Then red hepatization. Then gray hepatization.
RBCs are cleared by macrophages, and the spacey, the fibrin and other deposits are still present in the space.
Okay. Now the RBCs are degraded. Okay, the intact RBCs are not there; they will be degraded. Okay, so the reddish color will not be present. And next, resolution.
The exudate is cleared from the alveolar space.
Okay, okay. Okay, so why hepatization? Hepatization means it is related to the liver, but why in the lung?
so liver is a solid organ and the lung is a
Consistency.
spongy organ. So due to the exudate, it becomes form like liver. So it is called hepatization.
Okay, the consistency of the lung will be changed to like that of the
Liver.
liver. So it is known as hepatization. Okay. So here you can see more than the RBCs, you can see inflammatory cells, and the macrophages are taking up the RBCs and all the debris they are trying to take up. Okay, so it is a stage of gray hepatization. Is that fine? Any problem? Any problem with this?
No,
No,
sir.
sir.
Okay, then we can move ahead, right?
Yes, sir.
Yes, sir.
Okay, describe this. Okay, before that, let me tell you, this is a section from a blood vessel. Okay, I'll tell you this is from a blood vessel, artery. This is from a artery. So how do you describe this? If it is from an artery biopsy, how do you tell this? Describe this first. So this is the luminal side, right? This is the artery. Part of the artery is seen, where this is the luminal side of the artery. Here you can see a necrotic core. Here you can see a necrotic core with cholesterol crystals. These are all the cholesterol crystals, and there is a fibrous cap. There is a fibrous cap in the intima, with you can see here are foamy macrophages, okay, containing lipid, and there are smooth muscles. This is a atheroma. So what are the parts of atheroma? What are the things we can see in atheroma?
At the top, we can see the fibrous cap.
Very good.
We can see the proliferation of smooth muscle cells.
Okay, smooth muscle cell proliferation will be there.
And in the center, we can see the crystals of cholesterol
crystals,
and the macrophage containing the lipid, foamy macrophages, and necrosis.
And necrotic core. Okay, necrotic core and fibrous cap. These are the things. Okay. So on angiography, a branch of coronary artery was seen, which was blocked in a diabetic male patient with history of chest pain. Okay, that means he had a myocardial infarction. Okay, so there was a coronary artery, branch of the coronary artery was blocked in a diabetic male. Okay, write 3 causative factors for atherosclerosis. So what will you write?
So diabetes, hypertension.
Smoking.
Okay. Others? Smoking.
Glucose diet.
Hyperlipidemia.
Stress.
Okay, stress, hyperlipidemia. So always try to say this in a managed way, whether this is modifiable risk factor or non-modifiable risk factor. Okay, first let's talk about modifiable risk factors, like you told, diabetes mellitus, smoking, okay, hypertension. These all are modifiable, right?
Yes, sir.
Okay, that means you can keep hypertension, diabetes, and all these things under control. So those are more modifiable. You can, but your age, your genetics, these are non-modifiable things. Can you decrease your age? No. Okay, now someone please tell the non-modifiable risk factors.
Increasing age,
Genetics.
gender,
Okay,
family,
increasing age.
family heredity,
Okay, genetics.
and family heredity, sir.
Okay, that is genetics. You are telling about family history or family hereditary condition, right?
Yes, sir. And gender.
Okay, gender. Which gender has more propensity to have a atherosclerosis?
In male.
Okay, in males than in females. Okay, then others?
After marriage, also female.
Okay. Okay, so this, you should know all the modifiable and non-modifiable risk factors of atherosclerosis. Okay, what are the 2 complications of atherosclerosis?
So myocardial infarction, stroke.
Sorry?
Myocardial infarction.
Okay, myocardial infarction and stroke. Okay, you should, but you should know the other risk factors. Sorry, other complications of atherosclerosis also. Okay, so identification points over sections from the blood vessel where there is presence of atheroma consisting of a fibrofatty plaque composed of fibrous cap with the smooth muscle fibers and inflammatory cells in the intima of the vessel wall, and a central necrotic core with foamy cells, cholesterol crystals, and cell debris. Okay, is that okay? Any problem?
No, sir.
Okay, then we'll move on with the 15th slide. Describe this, please.
So it is a section from skin.
Okay.
Capillaries lined by endothelial cells.
Very good. There are
Many
proliferation.
capillaries lined.
Okay.
And the capillaries are separated by a septa of connective tissue.
Very good.
And most capillaries do not contain blood cells.
Okay. Okay. So here you can see there is proliferation of capillary-sized small blood vessels. That's why the name is capillary hemangioma. Okay. There is proliferation of capillary-sized small blood vessels. Here you can see there are multiple small-sized blood vessels. Although the size is different, there is variation in size, but the size is mostly small. See this. These are all small blood vessels proliferation. So there is in between these blood vessels, there is connective tissue separated by the connective tissue. And you can see RBCs within this blood vessels, but there are also capillaries without RBCs. So this is a capillary hemangioma. When you see this much capillaries, okay, these capillaries are also lined by endothelial cells. If you see here, these are all endothelial cells. They are lined by endothelial cells. Okay, these are all endothelial cells. They are lined by plump endothelial cells, are slightly not flattened. So a history can be a 20-year-old male presented with a bleeding polypoidal lesion on the skin, biopsy taken from the skin lesion. Identify the lesion, you have identified. And mention 2 points to support your diagnosis, you have already told. So it can be section from the skin shows lobules of thin-walled capillaries lined by endothelial cells. Connective tissue septa separate these lobules of capillaries, and most of the capillaries are devoid of blood. But there can be presence of blood. So 16th slide. Describe this.
Dilated blood vessels.
Okay.
Blood vessels are filled with RBCs.
Okay.
And the intervening stroma is very less.
Okay, scant intervening stroma. Okay. But what is the size of the blood vessels?
Larger.
Okay, large. Very. The size is large. Okay. There are dilated vascular spaces. If you see here, large vascular spaces are seen containing RBCs, and the intervening stroma is scant. So this is a cavernous hemangioma. This is a cavernous hemangioma. So that is the difference between a cavernous hemangioma and a capillary hemangioma. In capillary hemangioma, the size of the blood vessels is small capillary sized by name itself. But here there are large dilated cavernous spaces. That's why known as cavernous hemangioma. Okay. and the intervening stroma will be scanned. So the section shows dilated vascular spaces or to the tumor composed of large blood-filled spaces, and the vascular spaces are lined by flattened endothelial cells and contain RBCs, and the intervening stroma is scanned. Is this okay?
Yes, sir.
Are you all understanding?
Yes, sir.
Okay.
Yes, sir.
Okay. Susan Gimire? Susan? Susan Gimire? Apur? Ashutosh Jha?
Yes, sir.
Can you please describe what you see in capillary hemangioma?
So capillary hemangioma.
Yes.
So there are capillary sized small blood vessels proliferation,
Okay.
which are separated by intervening septa containing collagen fibers.
Okay.
And the
There will
blood
be
vessels are
proliferation of
divided,
capillary sized blood vessels, and then
the blood vessels are devoid of blood cells and blood,
okay.
and the section is of skin.
Sorry, what do you tell at the last?
The section is of skin.
Okay, okay, okay. Okay. Kushal Kesi? Kushal Kesi? Kushal Kesi? Kushal Kesi, are you there? Okay, Tanuja Khatri.
Sir,
Yes, sir.
Can you please describe the findings you see in cavernous hemangioma?
So presence of large blood vessels filled with blood.
Okay.
Intervening stroma is scanned.
Very good. What about the endothelial cells? They will be lined by flattened endothelial cells. Okay. Okay, let's go to the next slide. 17th number. Describe this, please.
Section from lung.
Very good.
Multiple granulomas composed of epithelioid cells, Langerhans type of giant cells, and chronic inflammatory cells such as lymphocytes are seen.
Okay.
Few granulomas show
Hmm.
central areas of caseous necrosis.
Very good. Very good. So here you can see the similar picture as we see in the pneumonia, right? These are the alveolar spaces, but just the difference is that here there is no presence of exudates, but adjacent to the normal area where we see the alveoli of the multiple alveoli of the lung, there is presence of multiple granulomas. Okay, granulomas, which are epithelioid granulomas comprising of epithelioid cells, Langhans type giant cells, and chronic inflammatory cells. Mostly predominant are the lymphocytes. This is a well-formed granuloma. Okay, there are multiple granulomas. Here you can see the next picture. Here there is a presence of central caseous necrosis. There is presence of central caseous necrosis surrounded by epithelioid cells, Langhans type giant cells, and there is a mantle of lymphocytes. So this is a granulomatous inflammation, and this is a tuberculosis. Why tuberculosis? There is caseous necrosis, there is Langhans type giant cell, and there is a well-formed granuloma. Sorry. So this is a pulmonary tuberculosis. Our question will be: a 60 years old male smoker and AIDS patient presented with anorexia, weight loss, cough, hemoptysis, chest pain, and fever. Okay, then you have to write what is a Ghon's focus and what is granuloma. So what is Ghon's focus?
So infiltrative neutrophils around the lesion, along with the lymphocytes and plasma cells.
Sorry.
So neutrophils and plasma cells surrounding the lesion.
Surrounding the
lesion of tuberculosis.
I'm sorry, that is not Ghon's focus. Anyone else? Anyone else? What is Ghon's focus? What is Ghon's focus?
It is the primary granulomatous focus.
Okay.
In the lower part of upper lobe or in the upper part of lower lobe of lungs.
Okay. So it is a granulomatous foci. Okay, in the lung. So when it is now, what is Ghon's complex?
So Ghon's focus plus involvement of a lymph node is called Ghon's complex.
Which lymph node? Cervical lymph node or inguinal lymph node?
Hilar lymph node.
Okay, hilar lymph node. The Ghon's focus in the lung, along with the hilar lymph node, which is involved, it is known as Ghon's complex. Okay, and what is granuloma? This we have already discussed. What is a granuloma? So this is a section from the lung. Multiple granulomas are seen, composed of epithelial cells, Langhans type giant cells, and chronic inflammatory cells. Few granulomas show central caseous necrosis. So this is a feature of tuberculosis of the lung. Okay, 18th slide. Please describe this. Describe this picture, microscopic picture.
Sir, it is the section from the lungs.
Okay.
There are malignant cells which shows pleomorphism.
Okay.
And hyperchromatic nuclei are also seen in the malignant cells.
Okay. Okay. So here you can see these are nests of malignant cells. Looks like squamous cells. Okay. They are infiltrating into the stroma. They are infiltrating into the stroma, and these tumor cells, if you see, they show pleomorphism. Are they looking identical? No. They have variation in size and shape. So they show pleomorphism. And here you can see these tumor cells, they have hyperchromatic nuclei. They have hyperchromatic nuclei or vesicular clumped. See the clumped nuclear chromatin. Okay, and they have these nucleoli. The main thing is that this tumor island or this tumor foci is infiltrating into the stroma. So this is a malignant lesion. Okay. This is a section from the lung, and malignant cells show pleomorphism with hyperchromatic nuclei, okay, which is infiltrating into the stroma. Now the question might be, a smoker with hemoptysis, breathlessness, and chest pain presented in the emergency. A smoker with hemoptysis. What do you mean by hemoptysis?
Sir, blood in cough.
Okay, blood in cough. So along with blood in cough, the patient had breathlessness. He is having difficulty in breathing, and he is having chest pain presented in the emergency. So write down the 3 paraneoplastic syndromes associated with this condition. First, you have to know that this is a bronchogenic carcinoma. Okay, and that also is squamous cell carcinoma if you are very sure. Okay. Now, what are the 3 paraneoplastic syndrome associated with this lung carcinoma? What are the 3 paraneoplastic syndromes?
Cushing syndrome,
Okay, very good.
hypercalcemia,
Okay.
syndrome of inappropriate ADH secretion.
Okay, SIADH. Okay, so you have to write just 3, but you have to know what are the related paraneoplastic syndromes. Okay. And what is the etiological factor for this condition?
Tobacco smoking, air
Okay,
pollution,
smoking, air pollution.
and occupational exposure to
Okay,
radiation.
very good. Very good. Occupational exposure.
And genetics.
Genetics. Okay. Fair enough. 19th slide. I think this will be the last slide for today. Or if time permits, we can go till 20. No, we'll just halt with 19 today. So this will be the last slide for today. Please describe this. The history is an 8-year-old girl. 8-year-old girl presented with bleeding per rectum. On clinical examination, a mass was found in the rectum, or a polypoidal mass was found in the rectum. So with this background history, what is describe this? What is this picture showing? Eight-year-old girl present.
So juvenile rectal polyp.
Okay, very good. Why do you say that it is a juvenile rectal polyp?
Cystically dilated glands are seen.
Okay, many dilated glands are seen. Okay.
So the cells lining the glands are not malignant or pleomorphic.
Okay, certainly there is no malignancy. Okay. Whatever is seen, these are all benign elements. There are glands, there are cystically dilated glands, there are branching glands, but nowhere ATPI is seen, or infiltration of the cells into the stroma is not seen, any pleomorphism or anything is not seen. So definitely it is a benign lesion first. Okay, which you correctly said. But what are the features in favor of juvenile polyp of the rectum? Now can you say? So this is a polypoidal tissue which is lined by columnar epithelium. Okay, lined by columnar epithelium is there, as it is from the rectum. So rectum is also commonly lined by columnar epithelium. So polyp arising from that rectum will also have a lining of tall columnar epithelium. Then the subepithelium shows rectal glands lined by cuboidal to mucus secreting columnar epithelium. The glands are elongated or cystically dilated and filled with mucin in the lumen. The intervening stroma is edematous and show inflammatory cells comprising of neutrophils, eosinophils, lymphocytes, and plasma cells. And there is presence of proliferating capillaries are also seen forming granulation tissue. Here you can see polypoidal. Okay, polypoidal mass where you can see multiple cystically dilated, okay, glands are there, and there is these glands are showing mucin, and there is presence of inflamed stroma. Inflammatory cells, multiple inflammatory cells are seen in the stroma. So this is a juvenile polyp of the rectum or hematomatous polyp of the rectum. So this much for today. If any problem with any of the slides, you can ask. Any problem with today's cases?
No, sir.
Okay, you understood everything. If you have understood everything, you should preserve that, and during the exam you have to show the same confidence. Okay? If you have any problem, you can note it down, or you can go home, study. Sorry, you are at home. You can study these things again, and if you have any problem, we can discuss again in the next practical class. Okay?
Yes, sir.
Okay, I think now we can hang up.
Thank you, sir.
Okay, thank you very much.
Thank you, sir.
Thank you, sir.